And our final speakers in this session are Helen Harris and Ross Harris from Public Health England to talk about averting the rising hepatitis C-related end-stage liver disease, that horrible curve that Steve showed us earlier. And I would like to thank both Ross and Helen, who've both been incredibly generous to us at the Hep C Trust with their time.
Okay, thank you very much. So, yes, this evening I'm going to be talking about the Public Health England model for the burden of hepatitis C. I'm going to have to be quite quick about this, but fortunately we've already had some descriptions of the kind of model that we've been using. Ours is sort of similar, so it shares it in some respects, and we've also used some of the same sources of data, but they were developed independently, so it's nice to see that some of the results seem to agree, and we're singing from the same hymn sheet, as it were. So just a very quick background. We know there's around 160,000 chronic infections in England, and all sort of markers of hepatitis C-related morbidity have been on the increase. And it looks like if nothing's done, then that's going to continue to rise. But the question is whether this can be averted by treatment. So we've got something called a back calculation model. This is the basic idea. We estimate past incidence and numbers progressing through a natural history model that would produce the observed data that we see. This observed data being some disease endpoint that we can actually measure and see sort of cases of end-stage liver disease and hepatocellular carcinoma. And then we combine that data with progression probabilities, the rates at which people move from one state to another. And using this method, we can kind of reconstruct the disease state structure of the population over time. So this is our model. It's pretty similar. We've used slightly different disease compartments. People move from infection to mild, moderate HCV, and then on to compensated cirrhosis, and then death and HCV-related morbidity. So these pink circles are what we actually observe, and the Greek letters, the deltas, are our transmission rates. And the idea is quite simple. It's just if we see a certain number of cases in one of these disease stages, and we know the rate at which people progress, we can work backwards and estimate the number of people in the preceding disease state. And we can continue to work backwards until we've estimated that whole structure of the population. So the features of our model, it's a statistical model, which means we use a likelihood and we fit it to observed data. We don't have to make any assumptions about past incidents in this because it kind of falls out of the back calculation model naturally. And the nice thing is, because we've used data on progression from UK-based cohorts and endpoint data in the UK and other bits of information, it's consistent with all those, with our sort of overall picture of hepatitis C. So the scenarios that we looked at maintaining current levels. We've estimated about 3% are treated annually. And we also look what happens if we double that over the next 10 years, and in the kind of ideal scenario where we scale up to complete coverage over the next 10 years, everyone being treated. We also look at the current standard of treatment, pegylated interferon, SVR rates of 60–70%, but far worse for people in more advanced disease stages. And we also look at the likely improvement in SVR rates that are going to happen over the next 5 years, so sort of 90% SVR rates. Although we're still a little bit cautious about the cirrhotics. It's not immediately obvious how good it will be for those. So we've been a bit cautious and gone for 60% rates. So here are the results. Kind of in line with what we've seen. This black line is the sort of current, if we don't do anything, keep treating at 3%, standard treatment. And so we're focusing on new cases of end-stage liver disease and HCC over the next 30 years, and that is going to continue to rise for quite some time before it begins to drop off. This dark red line is kind of if we stop doing anything, no one's treated. So current treatment is going to do something, but it's not that much. And then the blue line is doubling treatment, and the green line is this complete coverage in the next 10 years. So even with complete coverage at current levels, it's going to be some time before it really makes a dent on the observed cases that we're getting. Right-hand panel's improved treatments. Current levels comes down a bit, but if we can get these improved treatments and double the numbers being treated, then it starts to come down almost immediately. And this is the complete coverage scenario with these better treatments. So it starts to come down very quickly indeed. Still not getting right down to zero, and the reason behind that is that we've assumed that it's still going to be imperfect with those that have already developed compensated cirrhosis. obviously if it is more effective in that group, then this line is eventually going to come right down to 0 as well. So in summary, the disease burden is very likely to rise in the short term, and increasing treatment levels could mitigate this, but the standard treatment at the moment isn't really going to be enough. And the improved treatment is going to make a much more immediate impact, especially in those difficult to treat cases in more advanced disease stages. And it also is something that needs to be done quickly. In the modelling that we've done, we find that things are going to have more impact if this increase in treatment and improved treatments are implemented quickly. Okay, so thank you very much. I'm going to pass over to Helen now.
I just want to look at some of the factors that are associated with actually tackling hepatitis C in an elimination context. And I've put this slide up here to show you that actually it doesn't cost as much as you might initially think. Now, this is just an example of costs to scale up treatment, and this just looks at dual therapy, but it doesn't actually matter what therapy we're looking at. It's just an illustrative example, and the same will hold true. Currently, the total healthcare costs of caring for our current chronically infected population comes in at this figure, £4,680 million over the next 30 years. And this is based on treating 3% of the chronically infected population per year. That's where we currently stand. Now, when you talk about scaling up treatment to people, they're sort of thinking, oh, doubling, 6%, how much more is that going to cost? What does it really cost to actually get up to treating everybody, 100% of the people, over the next 10 to 15 years? And you can see that actually, when you consider the costs of dealing with the disease that you avert, it's actually not as much more in real terms as you would think. An additional 1,460 million over the next 30 years, and that's to scale up to complete coverage of treatment over the next 10 to 15 years. This comes out of the mathematical model. Now, obviously, when new treatments come along, you get more healthcare savings, greater benefits, but it is going to cost us more. In terms of implementation, I think we just really do have to stress again the key importance of getting to those groups that actually need the treatments. This is about accessing hard-to-reach people. We always talk about hard-to-reach populations, but if you speak to those populations, they'll often say, well, your services are really difficult to access. Depends where you're looking from. So really, it's about getting these treatment services, and I know throughout the UK, lots of people are working really hard with innovative designs of getting services structured correctly so that they're accessible to the key groups that need them. So we're talking about in-reach to prisons and drug services, treating in primary care and so forth. That's going to be absolutely key in tackling this infection. The other issue, of course, is we've talked about cost-effective. We know we already have cost-effective, nice approved therapies, but this is an issue, affordability of the new treatments. And that is why advocacy and local commissioning needs to be so strong if we're going to scale up our treatments. And it's also critical that locally commissioners gather data on outcomes locally, and that this is available for national monitoring so that we can show how well we're doing. You've already heard from a couple of speakers, it's undeniable that the impact of oral treatment regimens with good safety profiles are going to be an absolute key player in terms of rolling out hepatitis C treatment into the community. The fact that these are on the horizon is really our key moment to go. So really, is elimination feasible? Well, high levels of treatment will certainly reduce prevalence, and it will certainly reduce disease burden. We've seen from the work that Matt presented that incidence will also likely come down. But these factors we need to be careful of. We need to look at the level of continuing risk from injecting drug use. So we need to know about the risks of reinfection and to what extent there might be a core group driving transmission. Now, if this is the case, we need to make sure that these individuals are reached by treatment and that they have the appropriate supportive mechanisms in place to help them change the behaviours. This will be absolutely key. We've talked about policy motivation. We've got plenty of government targets in place, all targeting at liver disease, reducing premature mortality. So we've certainly got lots of policy drivers. if anyone had any doubts about hepatitis C being an inequalities issue, we know it's a disease of current and past injecting drug users, that it also affects many minority ethnic populations who come from areas with a high prevalence of infections. So tackling hepatitis C will certainly be important in reducing health inequalities. Finally, just the last slide, I wanted to just focus on some of the things that locally people need to be thinking about currently. There is a PHE template which exists, which you can simply just select your local DAT, it's by drug action team area, and it will tell you how many infections there are in the locality. It will tell you how many untreated individuals there are. And this can be used by commissioners to help them commission services. It's also important to ask yourselves, is local provision in place to promote and offer testing to those people who are at risk of infection? And there are nice guidance there to help you do this. And we've talked a lot about care pathways, which will be absolutely key. And again, we need to be certain that care pathways are in place so that when we do reach out to these groups, get them tested, that they do actually not only get tested, but they actually get into treatment and see it through. And of course, needle and syringe programs need to be adequate with sufficient coverage, because we would be fooling ourselves if we didn't recognise the importance of prevention in this particular. Getting individuals into drug services and ensuring that those individuals who put themselves at risk stay safe is absolutely critical. Thanks very much.